Welcome to the Rural Road to Health, the podcast about rural health, rural careers, and rural communities. I'm your host, Dr. Veronica Rasic. Hi everyone. Joining us today is Dr. Tariq Jagnarine. He is a family medicine doctor living and working in Guyana. He has experience in working with Indigenous communities, and he is also the current program manager of the National AIDS Program Secretariat. Hello.
Hi, Veronica. Thank you for having me, and hello to everyone.
Thank you very much for joining us today. So, to kick off the interview today, I wanted to ask you a little bit about how you got into rural health.
Oh, so first, as a family physician, it's a specialty that is quite new to Guyana. Most of us, when we finish med school, we're placed into health centers, especially in rural communities, and we start working as doctors. We don't necessarily do our residency program, but
Mm.
as of 2014, residency programs were introduced to Guyana, but family medicine wasn't among the first set. In 2016, family medicine became an option, and so I applied. I studied family medicine, did my residency, and upon completing, we were able to be introduced to the Wonka team and the Caribbean team as well. And the idea about rural medicine was introduced to me because I had a passion for working in rural communities, especially with our indigenous population. And then I saw an application that was open to have an ambassador, and I was like, okay, why not? Let me give it a shot. And so here I am, almost a year into being a rural ambassador.
Yes, I didn't mention that Tarek is one of our Rural Seeds ambassadors, and we're very happy to have him. So, thinking about kind of Guyana and what the population and community is like where you work, can you tell us a little bit about that and what the kind of specific characteristics of the area that you live and work in are?
Sure. So allow me to explain a little bit about Guyana. I think a lot of persons often confuse Guyana with Ghana from Africa. Guyana is a very small country found in South America. It's the only English speaking country. We're not that populated. We just have around 800,000 persons. Most of our populations are on the coastline, and there are a few indigenous population, very tribal and still a bit aboriginal group of Amerindians that are within the hinterland regions, like Arawaks, Caribs. We have a bit of the Wapishianas, Patamonas, Waiwais, and among others. And so I work principally at a part in Guyana called Region 1, Burima Waini. That's the top of Guyana. And principally, I do a lot of work with the Arawaks, the Caribs, and a bit of the Waiwais. And of course, with time, you have other race that are intertwining with these indigenous population. But it's a joy to see how slowly you can work with them, learn their culture, get to know them, and still incorporate a bit of my culture because I'm from an Indian background, and they learn so much, and the things that I've never I knew of that I go and I learn, especially cultural, even medical too. The things that we would commonly see in the coastline urban area, we generally when we go to these indigenous population, we don't see it. So I do a lot of work with the in terms of family medicine, but also I do a lot of work with STIs and HIV in the community because right where Region One is, we have a spillover of the Venezuelan population too that comes over, and so we're having a little bit of effect from that. We I also do outreaches in other parts of the country, which is close to the Brazilian border. That we'll have a few of the Brazilians coming over, and so yeah, that's basically Guyana in a
Sounds very
nutshell.
interesting.
Yeah, it is.
So, kind of thinking about the indigenous communities, do they speak different languages? Do they have different cultures? How does that kind of interact within what you're seeing and how you're practicing?
Yes, they do, and I forget to mention that, Veronica, because we have nine different tribes, as we call them, of Amerindians, and each one of them have their own language. And this happened to be a language, a dialect as we call it. It's not a written dialect, they just speak it, and so it's hard to learn. So often when we go, we have to work with persons who may know English, and they would translate to persons with whatever language they speak, whether it's Carib or Arawak. I do speak Spanish and Portuguese, so it's easier to work with the migrant population from Venezuela and Brazil. But when it comes to the
Hmm.
Amerindian population, it's quite difficult. However, we've been managing, we have good translators. We work with the chief of each one of the tribes. Those are persons we call the Tushaus, and they've been very supportive on the ground and getting work done.
That's very nice. And how do you find um, interacting with the different groups of people? Is there different health beliefs within different groups? Is there something that you find is more challenging when trying to provide healthcare services? How has that been for you?
Well, initially, when I started working with them, just understanding the culture was difficult because, for example, when you look at some of the chronic disease, diabetes, hypertension, even some of the thyroid related issues, their culture, their way of life, when you try to make a little changes, it's hard because uh, they're not accustomed to the modern way of living, especially like those in Letem, Region 9. Persons still live under what we would call those small tents and those huts, and they use a lot of cassava. They use a lot of ground provisions, and so when you're trying to change up their diet, change up their lifestyle, it can be difficult. So it takes a little bit of adapting, working, educating the population. So we've started to work a lot with the youth so they can understand from an early age. But the older population, it's a work in progress. They're slowly listening, and I think a lot has to do with the buy-in from the cultural and the traditional leaders. Once they
Mm-hmm.
buy in, and we would go to the church, we would go maybe to their meetings and try to have the leaders encourage them to understand what we're trying to say. But it's a slow progress. We are making progress, and
Mm-hmm.
if you look at a lot of most recently, I think 2 months ago, some of the region, Guyana is very mountainous in the hinterland region, and so some of the villages it's hard to reach because there's no roads. You have to use trails or you use the river. And so what we tried to set up satellite services and started telemedicine. But even that is a little bit challenged because the language is an issue, and having the patients understand what we're saying and following through with our plan. But we've started and some success, but with some challenges too.
Mm-hmm. And so you touched upon what kind of healthcare services are available. So you said there's some telehealth, there's some satellite clinics. Can you expand on what the primary healthcare team is like where you work?
So most of the principal region where there's like a central hub where you have a lot of persons, we do have like polyclinics, clinics that can afford a fair amount of healthcare services. And so those clinics are well equipped with doctors, social workers, case trackers and navigators, most of the services you can think of. But the satellite clinics that are hard to reach, we try to set up health posts. And at each health post, we would try to train someone from the community to become a community healthcare worker. And they provide that level of healthcare service. It may not be as extensive as one from a polyclinic, but at least they can say, talk, counsel, find out what's the basic complaint, and they now in turn would reach out to us through via telephone or via internet access, satellite phones, or even the telemedicine and relate to us what's happening. Sometimes we would then try to pack the medication packages and have it delivered to them. It may take a day or two and get it to them. If it's an emergency, we'll tell them, okay, send them out immediately via the water ambulance or a road ambulance quickly to us at the polyclinic. And even sometimes at the polyclinic, if we can't handle it in that level, we would then have to call in one of the airplanes or the choppers to send them out to the regional hospital or the central referral hospital so that they can receive optimal treatment.
Mm-hmm. And how far away are you from the bigger kind of regional hospital center?
So in Region One, in terms of flight, it's just about an hour 15 minutes with an aeroplane. If it has to be by boat, that takes very long, and so it's not that conducive. Um, and some of the clinics, in terms of if I'm in Region 1, those satellite hubs, as I call it, health posts, it can be as much as 3 hours by road or even longer. Sometimes they take almost like half a day, 12 hours to get there. By boat, it can be a little bit shorter. And so
Mm-hmm.
we manage.
Mm-hmm. And when the communities are accessing the satellite clinics, how are they arriving to the clinic, and how far away is the clinic from where they're living?
I really like that question because of lately I observe a trend where most of them, despite they may be ill, we're just talking about maybe say a common flu or diabetes or hypertension, nothing acute or critical. I noticed they try to choose on the market days or the days they do a bit of trading, come out
Mm-hmm.
from those villages on those days, like it's either Tuesday or Saturday. I noticed. Then they will come down on there, and then they try to come to the polyclinic and see doctors. And so it's been working. We try to do outreaches to and go into the village as often as we can. Of course, staffing is an issue here. It's not that we need a lot more persons to have that passion for rural medicine,
Yes.
and so that they would want to come out. And it's not just with healthcare. Even when you look at teachers, police officers, soldiers, not everybody wants to come in these regional areas and work. But being here alone, the satisfaction you get when you just make a difference in one person's life, and that it impacts the family, it's very satisfying.
Yes, I believe it is. And if you find that you're struggling to get healthcare workers in, does that mean that the services aren't available on certain days or weeks for those satellite clinics, or how is that managed at the moment?
Yeah, sadly sometimes if we don't have a healthcare service available, um, it will not be offered. But what we've started to do, we've started through the Ministry of Health to have at least quarterly visits of specialized service. So a team of multiple specialists would then start trying to move throughout the country, not just Region 1 where I am or Region 9. They try to go throughout the country and ensure, well, look, we're going to do surgeries, we're going to see complicated gynae cases, eye exam, dental exam. Of course, like I said, if they're very complicated, acute, and need immediate intervention, they would come to us and we would try to refer them immediately to the appropriate site.
Hmm. And do you find that the more rural and remote communities try to avoid being sent to the hospital?
Yes, yes, yes. And I guess this is by accident that that's a trend around the world because many of them they hide their complaint, knowing that sometimes that they would have to go out to Georgetown because they don't understand the way of life in Georgetown, and often they prefer to be on be with their family, their homes. A lot of them they practice the farming life and hunting, and so many of them they prefer, even though they're ill, to stay on that farm, stay with family. I see it a lot with the gynecological cases. For whatever reason, if it's complicated and we have to send it to Georgetown or a capital, or to one of our regional hospitals, they come up with all sort of excuses. They don't really want to go, and I really could understand. Imagine being in a setting where nobody understand you because of a language
Mm-hmm.
barrier, access to money, access to the means to move around. It is challenging, but we've slowly put up systems in place like setting up maternity homes. We've employed case trackers and navigators to go with persons when they're going out to these facilities. We've even sent them with other family members so that they can get that support when they go out. It's not an exact science, but we're
Mm-hmm.
recognizing the issues and trying to put measures in place to help.
And so you touched upon kind of maternity services, which was what I wanted to ask. So, how are maternity services in those areas? Is there a local center that they can go to so that women can give birth? Is there midwives that come to check on them? How is that set up for them at the moment?
So one thing I'm proud of is that the Ministry of Health would have invested a lot as it has to do with, maternity and child health. Of course, we're trying to ensure that there's zero mortality and related to both issues. And so they would have invested a lot to ensure that their midwives trained, and in most of the communities, most of the community healthcare workers, we try to train them in those areas. And so there is adequate coverage. The complicated cases, we try to train them to recognize when they're going to happen quickly, send them out to us for whatever is factor, whether it's multiparity, hypertension during the pregnancy, gestational diabetes. Once you recognize it, send them out to a clinic that can adequately manage. And so that has been working well for us in terms of when it comes to maternity and child health. There's good coverage also for kids vaccination and covering evaluation of kids.
Hmm. And with those kind of general checkups, is that something that the community health worker would do, like the vaccinations and the general monitoring, or would someone else be coming in to do those?
So there is the community healthcare worker that helps, and we try. We have a few nurses too within those areas. We do have the nurses that would go at specific days. We call them with the maternal child health days. We set that, I think it's Tuesday, Thursdays, and so the moms and the kids would show up on that day, and then we ensure there is adequate coverage of personnel.
Mm. And how important is that kind of good relationship and good communication with tribal leaders for helping to provide healthcare to the community? Is that a kind of integral part of it? Have you found
Most
that that's
definitely.
important? Yeah.
Yeah, most definitely. I don't think we can achieve the success we've been seeing without having the buy-in from the Tushaus, because they're the ones who recognize persons when they're ill, they're missing clinic, they go and get them. They help us too. Rungs up and send out boats or send out bus or anything to send persons to come to the healthcare facility. They're the ones who may have access to telephones and the satellite phones. So they're the ones that would put in that call to engage us to tell us, look, we're having this issue, see how best you can help. So they've been very supportive. We keep training them too. Most of the trainings that we have, we try not to exclude them, but we go to their meetings. They have their annual Tushao Council, and we would go sit. Of course, try not to intervene and impose on them, but allow them to share what are the challenges, and so that we can put measures in place to help them too.
Hmm. And with kind of thinking about the indigenous communities, do they have kind of traditional healers or traditional medicine that they want to incorporate into their healing process? What does that look like?
Some of the communities, the more really rural and mountainous or deeply riverine communities that are very still tribal in their approach, will use a lot of herbal medicine as part of their treatment regimen. Whereas the more the community is closer to an urban area, you notice they're stepping away, and they may rely on the clinics that we have. But there's that still this that integration that would happen. Sometimes you give them meds, they still go home and try a little bit of herbal approach. And a lot, when, for example, abortion is something we've been trying to press a lot upon them, that we prefer let us handle it in clinics, and that's something they try to handle a lot within their own with their own approach, their own horrible manner. Even some other illnesses that sometimes there's no bearing with the herbal approach. They still try to do their own system of treatment. So it's quite intertwined, but it's something that is slowly they're letting loose of, and giving
Hmm.
us that level of respect, that level of assurance that they appreciate what we're doing, and they trust us too.
Mm. And is that something that you've had to learn about, kind of their way of treating things? Is that important when you're thinking about what treatments you're going to give them?
Yes, yes. Yes, I find myself sometimes, because I've learned a lot too, of herbal treatments and traditional treatment that they would use, and I try to read up evidence-based approach around them. And so once I see there's a little bit of beer, and I find myself of lately do encouraging them to use some of them if they have access, and combine both approach, of course, pharmaceutical and the herbal approach, and it's getting some success. It takes a lot adapting to. I mean, coming from a setting where meds, pharmaceuticals, that's the way to go, and trying to
Hmm.
slowly allow them to buy in, and not reject everything, but still use the meds. It's a slow process, but it's good.
Hmm.
It's a lot of work to understand.
Mm. And kind of touching on the medicines side of things, how is distribution of pharmacies and getting medications out to people? How is that in the remote and rural areas?
Ah, well, in most of these areas, the only source of getting medication is from the clinics, the health post, the health center, or the polyclinic. And if it's a health post or a health center that is very far that we can't access, often, like I said, they would have to call us, tell us what's the issue, who are the patients, and we would now package these medications, and we would either use boats, ATVs to travel on the land terrains and get these medication to the community. We do this on a weekly basis, of course. In the afternoon, we'll drive, drop them off, and try to get it to them. Some communities where there's a health center and a health post, there's adequate supply of medication, so persons can come to us and get their medicine. And from a monthly base or every quarter, we would try to access drug from the capital, and so that goes out to those areas.
And in Guyana, what kind of health service is there? Is it universal healthcare coverage, or are people having to pay for their medicines or their care? What does that look like?
Oh, in Guyana, all health services are free. There's no cost to any health service or consultation or meds or anything. Everything is free.
Okay. And so, thinking about your training, so you said you did the family medicine residency. Did you receive any other kind of more specific rural health training? Is that available in Guyana?
There is an opportunity. I got some rural health training through Canada. I did an observership in Canada for a short while, University of Ottawa. I had some training there. We would have the Ministry of Health would bring in teams that keep training us in rural approach. But majority of your practice would come from experience being a while in the communities, because each community you go, it's different. It's not the same. There's some common trends, but at least 80% of what you do needs to be adapt and change to fit to that community.
And is there a medical university in Guyana?
There is several medical university. One from the University of Guyana that is somewhat it's not free, and there are a few private offshore universities too.
And do most of the doctors that work in Guyana receive their training in Guyana, or do they tend to receive their training abroad?
Um, at least majority of the current doctors we have would have been trained through a partnership we had with Cuba, who would have trained a lot of our doctors, and some of them are trained also from the Venezuela and University of Guyana. But not all of the persons who are trained from the University of Guyana are given the opportunity to go and practice rural medicine, because I don't think their course gives you that insight to rural medicine. The Cuban course that we did, they did a lot of rural medicine because they had an entire module and course tailored to that, and so
Mm-hmm.
it's a lot more easy to use those doctors.
Mm-hmm. And thinking about kind of other training, so for healthcare workers, nurses, is that something that's also done locally, or how is that set up at the moment?
Right. Most of our training are done locally. When we recognize there's a deficit, whether it's you need a X-ray technician, a physiotherapist, a dental technician, we have in Georgetown a nursing school, and some of the other major cities, Linden, New Amsterdam, they would have nursing schools, and not just nursing schools, they would have schools, and so we can have the persons come out. They can do microbiology, lab tech, and various other pharmacy assistant courses, and once they're trained, they return back to their community and provide service.
Hmm. And are there any barriers for Indigenous people that are trying to train to become nurses or doctors? Is that
Uh,
something that's happening, being worked on? How is that looking in Guyana?
Most definitely, there are barriers. I mean, adapting to the new culture that you're going to face when you come to a city, adapting having to use the different technologies, classroom setting that may be a bit online as well as in person, adapting to the way of life of not and the kind of food and the different culture that we're going to have here. And then at the same time, too, the pace of teaching can affect them. But what we do, we try to make the program work for the indigenous population. So if we realize that, well, okay, this person did come out for this training, we need them to go back and get work. We work with them at their pace and at their constraints too.
Hmm. And how many, if you know, um, Indigenous people have been trained to be healthcare workers?
I know annually the school try to put out at least two to 300, and it's a lot. They've been doing it since I know 2000 for a while, and so we have, and that's why I'm saying I'm happy that we do. Eventually, we're having that adequate staffing. The major deficit has to do with having sufficient doctors, medics, or social workers. So we do have good coverage when it comes to nurses. Sometimes we do have good coverage when it comes to a community healthcare worker. But in terms of pharmacists, doctors, medics, social workers, we do have a deficit because the programs are longer and a little bit more rigid. They're accredited too, and so not every person wants to do it, and not every person comes out successful.
Hmm. And so, thinking about the whole situation in Guyana at the moment, what do you find have been the challenges for you in your practice?
So some of the major challenges would have to do with policy, having proper policy in place that guides us and in terms of implementation. So you have not just policies, regulations too that you need to adapt to. Regulations that are in the capital and regulations down that maybe in an interland community that can be far different. And then when it comes to access to some resources, because what you may have here you may not have in an interland region, and definitely you have to adapt, you have to make whatever you have work. There's often you have a deficit of meds, have a deficit of resources, and so you got to use whatever you have in the local setting to ensure that you're well equipped and you could provide the best service available.
Mm. And what kind of communication do you have with policymakers if you do?
Well, for me, I'm a policymaker to be in the program director for the National AIDS program. And so I can easily reach out to persons within the Ministry of Health and ask for favors, ask for whatever is a challenge I have, ask to have solutions put in place. So it's easier to navigate. But other doctors on the ground who are just clinicians, they do have a lot of difficulty. For example, calling a medivac might be a lot longer for them. Getting meds or getting any policy change within a community can be a lot longer. And so that has been challenging, but it just requires a little bit of working around, working with partners, building that relationship from all angles. And it may not just be a ministry issue, but working with other ministries that can assist you in getting things done in a efficient but an appropriate manner.
Hmm. And kind of touching upon that side of things, how did you get into that policy side or the program management for the HIV/AIDS program?
So ideally, I do have a double specialty. I'm also an endocrinologist and a diabetic specialist. I did a lot of work because of being an endocrinologist. I generally moved around a lot throughout the clinics, and throughout Guyana, and so I got to see what was on the ground. And then there was this need at that time at the ministry to have someone um, who can help from a public health perspective with diabetes and sorry, not diabetes, with HIV and STI. And so I was approached, and so I was like, sure, let me give it a shot. Because when you look at my CV, I don't think I knew anything about public health and policy, and budgeting and strategic planning. I took that opportunity.
Yeah, and how have you found that kind of transition first from endocrinology to family medicine and then kind of into that public health policy sphere? How have those transitions been for you?
It's 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 uh, it's different. I'm trying to find words to tell you, but it's not the same. It's a lot. It's lots of change. It's been rapid for me, but I like it because I'm it's grooming me in a lot of areas to become a lot more well-rounded. Um, the work is different in a clinic. You can see and help about 40 to 60 patients in a given day. While from a public health perspective, the things that I develop, I'm seeing the ripple effect it's having that impacts the entire country and entire region. And so I'm liking it. It's I'm very appreciative of the opportunity as well. And I think most healthcare workers, most clinicians, at some point should try to do a little bit of public health. It helps you to understand the system a lot more. And so when the challenges come up, you know how to navigate them a lot better, and it helps you to even network a lot too. So you know how to get things done in an appropriate manner.
Mm. And with that kind of width and breadth of practice, do you feel that's something that you've been able to do because you're in a more rural area in a country that's more rural? Or do you think those kind of opportunities would have possibly come up just in the same kind of way if you were more urban?
Um, I think a lot had to do because of being qualified and not with the locality of where I worked. Yes, the ministry has a system in place where before they can send you on additional studies and scholarships, they pay for some of your studies. You must do work within rural communities, so that played an impact too. You at least should complete a year to 2 years in a rural community, and so having done that, I was able to get to do additional studies. But a large part had to do with having that passion too. Persons recognize that look, you, the individual likes what they do, so streamline them to that area, and so it better helps the community and the country.
Definitely. And so, to speak a little bit more about the kind of HIV program that you're working with, what's going on there and what kind of things have been done in Guyana around HIV and AIDS?
So Guyana has been making great strides when it comes to the HIV program. We're one of the leading countries in the Caribbean to actually start getting achieving epidemiological control. In terms of, I'm not sure if you're familiar with the UN 8 targets of 95, 95, 95, where each country around the world, they should have at least 95% of their population, they should know their status, and that 95% of them, at least 95 should be placed on treatment and retained on treatment, and at least 95% of them should achieve viral load suppression. Guyana, we're currently, in terms of the first 95, we're at 96%. At least 90% of our population who are positive, they know their status. We have some work to do in the second 95, where only just around 80% of our population are on treatment and retained on treatment. And a large part has to do with where persons, when they're put on treatment because of their trade, whatever trade they apply, whether some of them are miners, loggers, they're involved with gold work, they go into the interland region to get work. So they may miss clinic for whatever reason. And as it has to do with the last 95, we're currently suspected to be at 94%. And so we are doing well.
Hmm.
We've one of the first countries in the Caribbean to develop a well-rounded hepatitis program too, hepatitis B and C, offering treatment, not just treatment as we offer treatment as cure. Most of the modern new best practices are here and available. We do use them, and whatever I'm saying when it's here, it's not just centrally but throughout Guyana, because we do try ensure that we reach even the satellite clinics. We offer PrEP, we offer HIV self testing, we work with dual kits, kits where you can do both HIV and syphilis testing, or HIV and Hep B and C testing as combo kits when we do. So there's a lot of work and that has been done in the HIV program. Of course, a lot more can be done when it has,
Hmm.
as it has to do with reaching the vulnerable population, the key population, working with the MSM population, commercial sex workers, transgender population, even the migrants, working with the indigenous people, getting to that, breaching that language barrier so that they can understand better behavioral and perceptive perception about sexual practices, and at the same time too trying to get them to use simple commodities as condoms, lubricants, and prep, and contraceptions too. It's been a challenge, but we're working slowly with them, and we're seeing a lot of results, good
Hmm.
results.
Hmm. And with that program, have you found that there are some particular drivers of HIV infections? Is it kind of more social behaviors? Is it something else that seems to be driving infections? What have you found?
For us, a lot has to do with, indeed, as you mentioned, social behaviors, especially in the key populations, the MSM population, the men who have sex with men, female sex workers. We see a high prevalence there too, and commercial sex workers. As I mentioned, we have a lot of migrants that are coming in the country from Venezuela, Brazil, and they're turning to sex work, and so that is creating an issue. And the transgender population. Not only that, for some time with COVID, what it would have impacted us, and work with adolescent population would have been neglected somewhat. And so the young people, many of them, we got to rethink our approach and try to get to them to change their perception and
Mm,
behavior. And then lastly, there's the new trend, two new trends that I noticed that is picking up: drug addicts as well as the chemsex. Young
mm-hmm.
people involved in chemsex, multiple in one occasion, using multiple drugs and being more cohesive and easily prone to having risky sexual behaviors. And then the drug addicts and tattooing is becoming another challenge here.
Mm. And do you find that there's a rural urban difference in those kind of causes, or is it generally the same in both areas?
Actually, the prevalence is a lot higher in the urban area compared to the rural areas. What I find, STIs are a little bit higher in the rural areas, but HIV specifically is a lot more higher in urban areas. And I think a lot has to do with the distance that you may find in some of these rural areas. There's not that huge congregating and partying, and a
Mm-hmm.
lot more exposure to elements that can actually be conduce to be a substantive risk of getting an HIV.
Mm. You touched briefly upon kind of what was going on during COVID-19 and the ongoing pandemic that we're in. What happened with healthcare services in those kind of rural remote areas during COVID? Were there difficulties, and what kind of challenges were you facing at that time?
So, healthcare work did not stop. We healthcare workers continue to provide services in all communities throughout Guyana during COVID. And interestingly, most of the COVID cases were in the urban areas because many of those villages, because of their being protected reserve areas and they're being somewhat restricted in terms of access, they would have shut down and limit persons leaving and going out. Of course, they apply their trade in farming and hunting, and so cases were minimal. It did impact many of the other programs in terms of vaccination, in terms of persons being on treatment for HIV, chronic disease cases coming to get their treatment. Many persons did not come out; they stayed at home. So what we had to do, we had to think up of new innovative ways of getting to people, such as providing multi-month drug dispensing, doing house-to-house visits and home visits, going to the communities and the houses and try to deliver vaccines to persons at their own homes. And so it did provide, it was successful. We were able to do it, and I'm happy that it's over and we're out of it because it did put us back somewhat in terms of healthcare
Mm.
and our numbers.
And kind of touching upon vaccines, were you able to get enough vaccines for your populations?
Yes, happily, many countries donated to us, including the USAID project, Canada, UK, India, even Germany, many of them. And so we had enough vaccine. Of course, we couldn't have had consistently one type of vaccine, but we were able to have a large amount of the AstraZeneca and even Pfizer and Moderna eventually came down here.
Mm.
Sputnik was one a big vaccine. We received a large amount. And so most of our population is first and second dose vaccinated. Few
Mm-hmm.
persons are trying to go towards the boosters, but it is available, and of course everything is free. There was no cost that was attached to it.
Mm-hmm. And so, with the whole pandemic that we've all been through, were there any kind of key learning points that kind of jumped out at you during that period?
Most definitely one, and especially now that I'm still working with the rural communities and HIV. What I saw was the need for community involvement, not just the community, but also CSOs, civil society organizations, NGOs, private sector to get involved with healthcare. Many of them came on board during COVID and provided support to persons who were sick, helping with the vaccine process, helping with the awareness campaign. We need that to continue, and in every other program you can think about, whether it's chronic disease, whether it's infectious disease, we need CSOs to come, get on board, and start working with us to reach those communities. And many of these CSOs belong to communities. They work with vulnerable groups. They work with groups that see them and understand them. And so they're the ones in a position who are in a better place to bring those messages and change that perception, that behavior and way of life of persons to understand that how they can be a lot more healthier and living
Mm,
longer.
yes. And along that line of thought, what have you learnt by working with Indigenous communities?
One of the biggest thing I've learned, and I'm pretty sure most of my colleagues who did rural medicine, is whatever you learn in medicine, just keep the theory. And in terms of your attitude and approach, be humble, go slow. Don't try to rush anything. When you go into those rural communities, learn their way of life. I mean, some of us may come from families that are affluent, and we are accustomed to everything being in an urban setting. But when you go there, it takes a bit of adapting. It takes a bit of uh, going basic. So I would say go slow, go basic.
Excellent advice. It's been really, really interesting hearing about your work in Guyana, the general health system in Guyana. And I guess my last question to you would be whether there's any current projects you're working on that you might be looking for someone to collaborate on, um, or any other things that you'd like to mention before we wrap up.
Yeah, I am working on several projects. Like, for example, Guyana, we're trying to achieve elimination of mother to child transmission of HIV. And that's something I'm actually trying to work within communities to ensure that we have better education around breastfeeding and HIV, ensure they're not breastfeeding. We're working with a bit of the private sector to ensure that we get baby formula so that we can actually supplement these moms and so that they can have a source of having meals and milk to provide for babies. So that's one project I'm on. I'm looking at also another project with common comorbidities that you would find with persons with HIV, especially in some of these some of the rural communities too, because HIV is no longer life threatening, it's
Mm.
life changing. We have adequate treatment. We have one of the best treatment too that is used around the world. We use TLD, a dolutegravir based drug, and persons are living longer. But being living longer means now you're going to start presenting with other chronic illnesses. So we're working on that. We have a HIV self testing project we're trying to push to ensure that all communities, each pharmacy, even every home can have a self-testing kit so that they can, at any time they feel they're at risk, they can have themselves tested and ensure that they prevent themselves from getting HIV. Among other projects, many other small projects we're doing. And so I think in closing, I really want to tell you thanks for having this opportunity. Thanks for having me. And for those persons who are listening and want to get into rural medicine, it may sound scary, it may sound a little bit daunting, but it gives you a lot more satisfaction to learn about a culture that you never know of, and just to see the impact you can make in a community that had zero, that you could take it to a level that had a lot more better services.
Thank you very much, Tarek. Is there any way that someone who's interested could get in touch with you?
Yeah, my email. They can. I can share my email. It's tariq.jagnarine@gmail.com. I'm available at any time. I generally work. I'm on call most days. I work 24/7. So anytime you can send me an email, reach out. Uh, we're not just only looking for persons to support us, but we try to collaborate. Maybe if there's a project that work well in your country, your area, and it's something that can be adapted to Guyana, please do reach out to me. If there's a funding sources that we can reach out and do projects, like many of our communities, there's a need for wells, there's a need for libraries and better education programs. Do reach out and share. For example, many of the girls would have to travel, at least walk about a mile or and a half to get to a river area to bathe, shower, and get back to their dormitories. And so we've been trying to look to see how we can get wells in place so that they can use. And so that's a project I'm also working on.
You're working on lots and lots of good projects. Um, Once again, thank you so, so much for joining the podcast. It was really, really interesting to hear about everything you had to say. Um, and yeah, thank you all for listening to us today.
Thank you so much, Veronica, for having me. Have a good day.
To continue the online discussion about rural health, you could join the Rural Road to Health Twitter community. The link is in the description below. If you have a rural story that you want to share on the podcast, you can contact me via theruralroadtohealth.blog or via Twitter at DocVi. Thanks for listening and have a great week.